Welcome. We're so excited to have you here today for the first of a series of sessions where we'll be looking at the radar implementation strength assessment and quality of care tools developed by the radar project through Johns Hopkins University. My name is Jessica Ferne. I'm the Director of Global Health Impact at CanWaCH. My pronouns are she and her. And we are so excited to be having this session. It really builds on an earlier session that we had just a few weeks ago with our colleagues again at Johns Hopkins, where we looked at the coverage tools, and there was a huge amount of interest from partners across the country on learning more about these tools. So great to see the response we had to these sessions, and we're really excited to be offering it together with GHU. So a few quick words before we get started. Everybody, I'm sure, is an expert on Zoom meetings at this point. So just to note that our technical support today is my colleague Min. Min is here for you to ask any questions you've got if you can't hear, or if you're having any issues joining or sharing your thoughts. Please write directly to her and she'll help you out. As well, the discussion for the most part today will be in English. Mais comme toujours, on vous invite de poser des questions dans la langue de votre choix et on peut faire la traduction si vous avez besoin. These sessions will be recorded. We want to make them available to your colleagues as well. As we'll talk about in a moment, after this kind of deep dive overview of the tools itself, there will be some follow-up sessions where you really look at specific topics. We'll be hosting those throughout the month of August. And then once all of the sessions are done, we'll be making those recordings available definitely on our CanWaCH website, and our GHU colleagues can tell us where else those might be. But we'll be sending an email to everyone to make sure that you know when those are up and that you have access to them. So don't worry, we'll be sure to let you know. Throughout, we invite you to post any questions that you've got in the chat. We'll be monitoring that as well. We're a relatively small group today, so you can also just take yourself off mute if you want to ask questions, but we'll try to keep an eye on the chat to make sure that any questions that you have or any feedback that you have gets addressed. So I'm momentarily going to turn it over to our GHU colleagues, but just in the meantime, and we'll post this in the chat as well, but we'll be referring to this website, isaqocfeedback.com. The password is radar2020 if you want to log in there. And again, we'll have it in the chat for you momentarily. So with that, let me turn it over to our GHU colleagues, specifically Melissa. Marx, over to you.
Thank you so much. I just want to start with saying how grateful I am to CanWaCH for hosting this, and it's so great to see all the familiar names here in the on the panel, and I'm really glad that you could join us. We've been talking with some of you guys for 4 years about these tools. Some of you we haven't met yet, but we're excited you could join because these tools were developed for you to evaluate your programs. And our goal for today is actually to orient you to implementation strength and quality of care and the radar tools, and show you how they've been used to inform program improvement. And it will also provide a way for us to tell you how to give us written feedback and how to engage with us for feedback after this session. We'll be doing breakout sessions where we'll go more deeply into each of the tools, and maybe I'll stop there. And I just want to welcome you on the behalf of our JHU team. And I want to now go to Marnie Davidson to ask her to give a few words of welcome.
Let's hope I'm off mute. Yes, very good. Okay, so welcome everybody. It's nice to see a few people who participated in most of the coverage survey sessions, and a really warm welcome to those of you who are participating in these sessions for the first time. It's nice to see a few new faces. So that's really, really great. And And thanks as always to Jessica's team and CanWaCH for hosting these sessions. They've in our COVID times, they've made this really a seamless transition into a virtual space. So thank you very much to the CanWaCH team for that. It's been a really successful series to date, and I think we're really pleased with how things are going. Everybody's now frozen, so I'm wondering if you can hear me.
You can. I can, Marnie, at least.
No problem.
We've got yes? Okay, great. Okay, thank you, thank you. So as Melissa pointed out, this has been a partnership that's been, great, thank you everyone, I really appreciate it. This has been a partnership that's been going on for almost a decade now, more formally since 2014. And this is really actually the exciting part of this partnership, where we really get to see these the 6 tools that Melissa and others in the JHU Radar Project team have been working tirelessly on for the past 6 years. So I think we're really excited to see how these tools have been developed at the stage they're at. And also, we've been working very closely with the Johns Hopkins team, Melissa, and then particularly Neff and Tim, to see how we can incorporate the use of these tools into developing our monitoring and evaluation strategy for the 10-year commitment on global health. So it's both coming to the end of using these tools for our current round of programming, and really excited to see the results of that, but also to note that these tools are what we're looking at these tools as being sort of formative for what we're going to be doing in the future. So along those lines, as Melissa said, these tools don't work if they don't work for you. And so the only way we're going to really get to that point is if you and on the GAC partners really engage with Melissa's team in providing feedback, so that they're going to really work for your programming. Because at the end of the day, irrespective of what we may want to see them done, how we may want to see them used on the global affairs side, they really need to be a program tool that works for your program. So I would highly encourage engagement, whether it's through the survey, whether it's reaching out to Melissa and her team directly, through email, through phone calls. This is an introductory session, so you can get an idea of what the tools are. Hopefully we had some good discussions today, and then take that back to your teams and your different organizations. And please, I strongly encourage you to provide and engage with Melissa as much as possible. They're extremely open to feedback. I think this is the critical stage for them in terms of making sure that these tools work for you. So with that said, I look forward to the discussion, and thanks very much, Melissa, Jessica, and everybody who's going to be participating throughout the session.
Thank you so much, Marnie, for those words, and we've really enjoyed the collaboration for the past years. Maybe I'll take a moment to just say first what the particular objectives of this workshop are. And we hope by the end that you'll be able to identify types of questions answered by the Radar ISA and QOC tools, and how results can contribute to program improvement. List and describe the contents of our tools, our tool sets. List and describe contents of one of the 4 content-specific tool sets in detail. And we hope that by the end you can access and provide feedback to the tools and sign up for August discussion workshops. And with that, I am going to make my fabulous team less nameless here, and I'll introduce myself and then ask them to, introduce themselves. I'm Melissa Marx. I'm an assistant professor at Hopkins, and I'm leading the ISA and QOC teams, and I'm one of the co-PIs of the Radar project. Emily?
Hi everyone, my name is Emily Frost. I'm a research associate on the ISA and QOC team, and my background is on maternal and child health programs, specifically in sub-Saharan Africa.
Elizabeth?
Yeah, good morning, everyone. My name is Elizabeth Hazel. I'm an assistant scientist, and I was involved mostly with the Malawi family planning implementations, and I'll be leading that breakout session shortly, and also the interpartum one in Tanzania. Thank you.
And last but not least, Diwakar.
Hi, my name is Diwakar Mohan. I'm also an assistant scientist with the Department of International Health at the School of Public Health. my primary background is as a physician, but I've become a health systems epidemiologist, and that's how I work most of the time these days. Good to meet with you all.
So great. It's an amazing team, and you'll see each of us in a breakout room. And maybe now is the time to say that we are going to have an introductory couple presentations and a short discussion section. And Jessica is asking for you to please, she's put the groups in the chat, and she's going to ask if you can just put your preference for breakout room in the chat so that she can start making those breakout rooms while we are going through the next set of slides. Anything else you want to say about that, Jessica?
Nope, just go ahead, type it right into the chat, whichever one of those topics. Please select one that you want, and when it's time to go into the groups, we'll break you out accordingly.
Okay. Anything further from the team before we jump into the content? Okay, so the first thing we want to do is just make sure we're all on the same page about what we mean by implementation, strength, and quality of care. Can everybody see my screen?
Yes, we can.
Awesome. Okay, now I got to get you guys to stop encroaching on it. I've got you guys sticking in the middle of my screen. Okay, that's all right. You guys are going to stick in the middle of my screen. So
we can't see those chat windows, Melissa, so go ahead.
Okay, this is an introduction to implementation strength, quality of care, and RADAR's tool package. So this is not new information for any of you, but I just want to make sure we're all on the same page about what quality of care is and where it came from. You're all familiar with the Davidson framework. He defined quality and approaches to its assessment back in the 60s, and his work has been has endured all of this time. And in fact, as we started making care more available around the world, especially in low and middle income countries, it became apparent that availability of care only wasn't enough. We had to focus more on quality of care. The Davidson structure, the Davidson definition includes structure, process, and outcomes. And we'll talk about these a little bit in this presentation. But at some point in the past few years, the WHO started putting out the call to focus more on qualities, including this Delivering Quality Health Services manual, and the Lancet Global Health put out this really important series on quality of care as well. So what we mean when we talk about quality of care is the degree to which health services increase the likelihood of good health outcomes. Wait, let me move you guys over. I can't see my slides. Of desired health outcomes and are consistent with current professional knowledge. This is our working definition of quality. And probably a less familiar term for you is implementation strength, unless you've been following us for the past 5 years when we've been talking about it. Well, implementation strength relates to the readiness to deliver services. In Davidson's framework, it's the structural quality, but a bit more. It's the doses of the services available. And some of the common domains of implementation strength are accessibility and availability, infrastructure, personnel, training and supervision, and commodities, having all the supplies and all of the medications that are required to even have a chance at producing high quality services. So why are these important? Well, if we can get people access to services, but we can't get them all of the commodities and trained personnel that we need, and the services don't meet technical quality standards, we won't see a difference in health. We won't see an impact. And I'm sure many of you have seen our impact model tool and our framework for for impact. And in our parlance, we talk about impact and outcomes. I know you talk about intermediate outcomes and ultimate outcomes, but this is just a simple model to reiterate the need for us to think about all the aspects of the causal chain from inputs to impact. And this is just a very simple example here. What we've done in RADAR is we've thought about evaluation as a series of questions. And if you were in the coverage survey seminar, you really focused on question 4, do women and children who need interventions actually receive them? If you participated in some of the RADAR seminars that happened a few months ago, then you looked at question 1, does the program focus on interventions that will have the greatest impact? And you talked about question 5, is the expected impact of the program occurring? And the list would have talked about modeling that from coverage. Well, for this seminar today, and for the 4 that will follow in August, we're really going to focus on questions 2 and 3. Is the program implemented at sufficient strength to achieve expected impact? And are the services utilized by the population? And are interventions and services delivered at the quality sufficient to achieve expected impact, focusing on activities and outputs? So our goals here are to determine whether a program can provide care at a level high enough to actually have an impact, and to identify strengths and gaps to inform program improvement. This is mid-course correction, not at the end of a program. So it also, ISAs and QOCs also can support evaluation findings, in particular to explain why a program did or did not have an impact. Why or why not a program didn't increase coverage. And this is an important thing that you need to know if you need to explain what happened in your program. So here's a slide that talks about domains and indicators. These are just examples from family planning, but I just wanted to put it up there to make this more concrete for those of you who think in terms of domains and indicators. I'll just pick one from the ISA side and one from the QOC side. Looking at ISA tool and supervision domain, we would look at the proportion of healthcare workers that receive supportive supervision according to protocol. And for QOC, we might look at technical performance domain, which is an example indicator is the proportion of providers that provided accurate information about a particular tool, in this case, injectables. So in our RADAR parlance, we do talk about our methods, and we have used these methods alongside of our tool. For implementation strength, we usually focus on provider interviews and in-charge nurse interviews, which include inventory of supplies and equipment and assessment of the provision space. And we look at provider technical performance quality. And we do this by direct observation with patient re-examination, record review, simulated clients, healthcare worker test and vignettes, and patient exit interviews. We have really found that involvement of the Ministry of Health and other program implementers in the assessment from the start increases the probability that folks will act on the results. We work in partnership using these tools with ministry and program implementers, and we have, as we have with some of you in the past. We think it's really important to give aggregated results to policymakers, but give individual indicators to program implementers so that they can pinpoint where remedial action or scale up of a successful program is needed and warranted. And as we know that prompt feedback of results is essential for making quick revisions to programs. So we developed these tools and tested them. While we're looking for change in programs, we are very practically oriented. We did take a quite academic initial approach to this. We did a desk review of ISA and QOC measurement tools and protocols. We solicited input from content experts, and then we tested our tools in field settings. We engaged our program implementers, Canadian NGOs and country governments, and we harmonized with local clinical guidelines and policies so that it would be truly relevant for the program and policies in the context. We designed and incorporated validity studies, which we won't focus on during this seminar, even though we'll mention them in the breakout rooms, including validating clinical vignettes using simulated clients, comparing in-person and mobile phone clinical vignettes, and comparing clinical vignettes and OSCE mannequins in the context of interpartum, and some other validity tests that we'll talk about in the breakouts. We collaborated with in-country partners to implement the evaluations in all cases and to analyze the data. And we conducted in-country validation workshops and disseminations. Where did we do this? Many of you might have been involved in some of these, and I know Marnie was involved in our early stages of Mozambique as well. So we did this in Mali on child health ICCM in 2 regions in collaboration with Credos and the Red Cross, both Malian and Canadian. We did this in Malawi on family planning and youth-friendly health services in all districts of Malawi, working with the National Statistics Office and Wadanda Limited. We did this in Tanzania on interpartum in Simiyu, and we did this with Ifakara and with AMREF. And finally, in Mozambique, we looked at nutrition counseling and referral in Inhambane province, and we did this with CARE and the National Institute of Health, or INS, in the government. So this is where I want to stop for now, and I want to pass it on to Emily, who will talk about the Mali implementation to show you a bit about the kinds of results that came out.
Thanks, Melissa. Let me pull up the presentation. Can everyone see the presentation? Great, I see some nods, so that's great. So as Melissa said, I'm going to give a brief overview of how we use these tools in our evaluation in Mali, just to show you an example of the kinds of things that we can measure and the information that we can glean from the evaluations. So the tools I'll be talking about are our ICCM tools. And a brief overview, for those of you who may not know, ICCM stands for Integrated Community Case Management. This is a strategy that is supported by and used by a number of public health programs globally, and it aims to extend the reach of health services to areas that cannot traditionally be reached by facility-based services. They do this through training community health workers, or CHWs, to provide these services in their communities. And ICCM targets child health, and specifically children under 5 with pneumonia, diarrhea, and malaria. For those children who are diagnosed with severe cases of these illnesses, or who present to a CHW with an illness that's outside of the ICCM purview, CHWs are trained to refer those children to the nearest health facility for treatment. In Mali, we partnered with a program that was implemented by the Canadian Red Cross and Malian Red Cross. And this program added a few different elements to the, added a few different elements to the program. So they added malnutrition as one of the illnesses that CHWs were trained to treat and diagnose. There was also a newborn surveillance component where CHWs would visit newborns in their households and their families from the day after birth until 45 days after birth on a schedule. And they did this to both look for danger signs in these newborns that necessitated referral to a health facility, and also counsel on some postpartum care topics. And we also, there was a family planning component as well, and we incorporated that into our implementation strength assessment of the program. To review the methods that we used for this evaluation, I know Melissa went through a long list of methods, and we did not use all of them in every evaluation. So for this evaluation, we conducted a CHW interview, and we did that both in person and over the phone. And this is one of the studies that Melissa mentioned, a validation study. And I'll talk more about this specific analysis in our breakout session. We also conducted observations of sick child consultations and newborn surveillance home visits with a re-examination of the sick child and exit interviews with the child and newborn caregivers. So what that looks like in the form of tools and in the form of field work is our implementation strength assessment is composed of the first three forms you see here. The CHW questionnaire, which asks in the domains of supervision and training. Form 2 is our commodities inventory, which covers everything from medications they need, supplies they need, materials, job aids, and then our record review and abstraction tool, which looks for utilization data and record completeness. You'll see there is a Form 4 missing here, and that was a case vignette tool. And we're not including that in the final package. And I'm happy to talk more about reasons for that in our breakout session. For our quality of care assessment, there are two parts. There's the sick child consultation and the newborn home visit. For the sick child consultation, our observation checklist is used by a data collector who observes what the CHW does and prescribes and diagnoses the child with during that consultation. And then there is an exit interview for the companion of the sick child. We then have a member of the study team who is a clinician perform a re-examination of the sick child. And in the analysis slides that I'll go into later, we use those re-examination data as the gold standards when we're looking at the quality of the care that the CHW provided and the accuracy of their diagnosis and treatment. For the newborn visit, we have an observation checklist again and an exit interview for the newborn caregiver. I'm just going to go through some brief results. These are some selected indicators in our implementation strength assessment tool. You can see that we have indicators about supervision and training, availability of materials, including some that are really necessary for CHWs to be able to diagnose and treat children, and also supports and job aids. For our commodities inventory, our tools include questions both on medication and supplies that CHWs have the day of the evaluation. So in person, our data collectors physically counted all of these medications and supplies. And then they also asked about any stockouts over the past 3 months of these supplies. So looking at our analysis and what kind of information that we were able to gather from our evaluation, as I said before, we compared the CHW diagnosis of the sick child to the study team clinician's diagnosis of the sick child. And so here we have results of accurate diagnosis. And you can see here that the numbers are quite varied for our MOLLI implementation, and specifically pneumonia was quite low at about 50% of children were diagnosed correctly by a CHW for this illness. We wanted to know also why this diagnosis of pneumonia, why CHWs seem to be struggling with this. And as I'm sure you know, one of the drivers of a diagnosis of pneumonia is breathing rate and diagnosing a child with rapid breathing. So we actually looked at the respiratory rate, the number of breaths per minute, as measured by the CHW and as measured by the clinician. And we looked for agreement, and we defined agreement as within 5 breaths per minute between the CHW's measure and the clinician's measure. And we did find lower than expected agreement between those two measures. In addition to diagnosis, we also want to make sure that CHWs in this case are treating sick children correctly. And so this graph shows the ability of CHWs to both prescribe the correct medication and also the correct dosage of that medication to sick children. You can see here that CHWs did really, really well at prescribing the correct medication, but really struggled with the dosage of the medication that they prescribed. For our newborns, some of the data we looked at was around danger signs. And so we have these 10 danger signs along the bottom of the graph that CHWs are trained to either ask about or look for in newborns. And you can see here that the numbers are quite varied as well. And there were a few, I believe about half of these danger signs were looked for or asked about in fewer than 75% of newborns. So from our analysis, we were able to pull out some key messages and recommendations for the Red Cross program. We saw that that stock was quite varied, especially between districts, and there were some key medications that it seemed like were commonly had no stock. So we recommended some supply chain strengthening in order to ensure that CHWs had the key medications they needed to treat these children. We also saw that pneumonia was not diagnosed correctly in about half of children. And we saw that this was driven really by the breathing rate. So we recommended more training on correct breathing rate counting. We also recommended some more training on dosage, on the correct dosage of medication to prescribe, as well as looking for danger signs in newborn children. And I was able to follow up with the Red Cross, I see Louise on this call, that they were able to hold some refresher trainings for CHWs in these areas that we recommended. So Elizabeth, I believe now is going to talk about our tool components.
Yeah, thank you. Can you hear me okay?
Yes, we can.
Okay, thank you. Yeah, so we just wanted to take a couple of seconds and talk about what's coming with our tool components, because not only is it the actual instruments themselves for various methods of data collections and compilation, but we've also developed manuals on how to implement these assessment, very detailed guidelines for the entire process from the planning stage all the way through data use for program improvement. These include detailed supporting documents such as sample size calculators, budget templates, training materials, agendas, and also interviewer performance checklist. And these are all based on what we've used and tested in the various implementations. All of the implementations included some component of CAPI. So we've got a lot of resources available for that, and also some guidelines on data storage, and also code for data management and analysis. So this is sort of what comes with our tool package for Radar, and we're hoping to get your feedback on all of this pretty much. So thank you, over.
So I think now is, I'll pass it over to Diwakar to lead us in a discussion and to lead us in answering of any questions that have come up.
Thanks, Melissa. I know this was a lot of stuff thrown at you in a very short period of time, and you'll probably have a lot of questions to ask. So this is probably a good time to ask these questions. If you feel shy, please type them into the chat box. We'll be monitoring the chat box. More importantly, I want to define the kind of questions that we want to ask, because we are going to be addressing many of these issues in a more intimate manner in the breakout sessions. So some of these that might need a lot of discussion, it would be good to kind of hold on to them for these breakout sessions and for our future August sessions where we can discuss each tool and question in great detail. Right now, we want you, if you have any broad questions on the kind of tools, kind of resources that we have as part of the radar project, and any general questions about some of these studies, we'd be more than happy to answer them. I assume everybody's shy.
Hi, Diwakar. This is Louis.
Hi, Louis.
Hi, thanks to you and the team for the presentation. I don't have a question. I just have one comment on the concept of these tools. I see them contributing a lot to human rights, because if we look at the element of accountability of the responsibility holders of in terms of human rights principles, we are all obliged to provide quality service to the communities we serve. So through these tools, we can see the quality of service, which is quite impacted by the how we implement the project, and we can identify some issues that would guide us into improving that. Hence, not only from a technical point of view and health, but also from a human rights point of view. Thank you.
Thank you, Louis. Those were very kind words. So one thing that I wanted to say is that many of you may have used similar tools or other related tools in many of your different programs and evaluations. So one key question that we wanted to ask was, have you used, can people describe some of their experiences if they've used the radar tools and if they've used other tools, and any comparisons or even experiences that you would like to share with us using these kind of tools? I'm assuming Louis is probably part of the team. They've used the ICCM tools in Mali. Anybody else who thinks that they might be comfortable talking about some of these tools in case they've used them, or even if you've not used them and you've had a chance to look at them, please feel free to field your questions.
Hey, this is Vaishnavi. I'm part of the Oxfam Canada team. I'm right now designing a quality of care tool for our projects in SRHR, but it is a little unfortunate. But I went down the path of CanWaCH has a quick assessment of quality of care tool that seems pretty useful, and we intended to do our data collection on an annual basis. So it seemed like a little bit more of a manageable tool because it was still relatively quick assessment. So now I'm like, obviously it hasn't been rolled out yet, so that's good. So now my next thing is like, now I have to figure out comparison wise. So I think it would be nice to actually hear some advice if anybody has any.
Perfect. So, well, one of the key things that are part of our tools, and I think Vaishnavi also expressed your interest in family planning as well. So Elizabeth might talk about it more in the breakout room and describe some of the more intimate details of all these tools. Our tools kind of span the wide range of activities that could possibly be done. For example, a facility assessment that could be done every 6 months to a kind of a in-field observation of care that might need to be done at less frequent intervals as well. Ultimately, the options are available for you to kind of tailor these to the range of questions you're asking and what do you need out of, what are your expectations of these questions? What are the answers that you're seeking, basically? I'm sure in the breakout rooms, we'll go into detail about each tool and we'll probably discuss this in greater detail. Melissa, do you have any thoughts about Vaishnavi's question?
Yeah, thanks. I guess I would say, yeah, give our tools a look and see if they give a more comprehensive view of quality? And if so, you could possibly do a quick assessment of quality on a more frequent basis, but do an in-depth focus on quality once or twice, as Diwakar said. And I also just wanted to re-emphasize that we don't see our implementation strength and quality of care tools as the evaluation for these programs. We see them as complementary and to the other tools like the coverage survey, or even looking at the DHS data to see what the coverage data say, and alongside of list and a good impact model. So we think of these two tools as sort of the middle part of your evaluation, where you want to see after things have ramped up and after you're sure the program is rolling, you want to see if it's doing what you think it's supposed to be doing. And then you can make your changes, your improvements, and then have a better chance of seeing impact afterwards. I'll stop there.
And I know resources and cost will probably be an important factor in deciding what kind of assessments that you might want to make. And during these breakout sessions, we'd be able to give you some kind of ballpark estimates of how much did it cost for many of these kind of studies. So I think that will prove to be a good discussion as well to help you choose some of these things.
That's actually really helpful. Also, one thing is the kind of personnel we need to hire to get these things done. Because obviously, I mean, you can't just pick up any evaluator to go in and do this assessment. So it's going to be interesting to have that conversation.
That's very much in line with what we would love to discuss with all of you.
Yeah, I mean, I think we can also say now that when we do implementation strength, we don't feel like it's necessary to have clinicians collect those data. But when we do quality of care, and we often do them at the same time, we do feel like in many circumstances, you do need clinicians that can do the re-examination to ensure that we have an objective assessment of the health condition of the patients. So yeah, I think your question is a good one, and it does depend on what you're trying to get out of that quality of care assessment in particular.
Any other questions? Okay. If there are no more questions, should we move into our breakout rooms and probably talk this in greater detail?
Yeah,
Okay. Yep.
Maybe let's give people one more minute in case they want to. Maybe I'll just offer another question. Have you guys used other tools to do facility assessments before, and how have you felt about those tools? I think most groups need to see how well their facilities or their community health workers are set up to provide a service. Does anyone want to talk about their experience with a facility or community-based provider, what we call implementation strength assessment?
Good experiences, bad experiences, all are welcome.
Hi, this is Lowe again. We use the health facility assessment tool of WHO, a simplified one, as a coverage survey to assess the implementation strength of health facilities we support in Mali in our project, in the MNCH project. And it was a shorter version, and we looked into the availability of staff, their experience, male and females, drugs, availability, equipment, lab equipment, and etc., relevant to MNCH services. That was only something equivalent to the implementation strength, not the quality of care. On the quality of care, we asked a few questions slightly without case management.
Louis, would this be like the SARA surveys? SARA, SARA?
I'm not sure what that is. It's a tool. I think I know that it's a WHO tool.
Okay.
I can share with you the questionnaire later.
Thank you.
And Louis, how did you find those tools? Easy to use, straightforward?
I think so. It was not difficult to use. We hired a consulting firm in Mali to do the assessment, and we sampled, and I think we sampled 50% of our facilities. We covered at the time, at the beginning, I think more than 100. And I think it took a day of assessment for every facility. And we used digitized data collection. Yeah.
Thanks, Louis.
I might just jump on for one of our experiences I had, particularly, I mean, Tanzania is one that I think a lot of people have experience with. I see Tanya Saluski on the call. We had used the JPEGO SBMR tool for a program and found it particularly heavy. So you could only do sampling and you couldn't translate a lot of that into routine sort of supported supervision. And so we did move towards more observed methods. And I think that was pretty successful because it didn't require you to sit there and actually do the observation of the clinical presentation and possibly have to wait a significant amount of time for that presentation to occur. So I like what the ISA QOC tools are doing in terms of integrating observation, because I think that lends itself a little bit more to being able to adapt some of those pieces to your sort of routine data collection in terms of doing your ongoing quality improvements.
Barbara, I assume you're there. So do you have any comments on the SBMR?
Yeah. Hi, this is Barbara Ross. I'm with FIGO. I'm very familiar with the SBMR process and assessment tools, and those tools are more for ongoing quality improvement than for evaluative purposes. You know, they aren't really intended for a more kind of streamlined assessment across facilities with a core set of indicators. But I think under the Maternal and Child Survival Program and the Maternal and Child Health Integrated Program, we developed a facility assessment package that included a combination of health facility readiness assessment and observational assessment tools to look at antenatal care and intrapartum care and postnatal care, including postpartum family planning. And so those had a more, let's say, streamlined set of items than you would find in the SBMR tool. And for the intrapartum care tool in particular, we also supported the development of a short index of quality of labor and delivery care that has an even shorter set of items. So, and I know MCSP did some assessment of sick child care and ICCM, I think drawing on the WHO tools, but I wasn't directly involved in that, so I can't really comment on, you know, the experience using those tools.
Thanks, Barbara. That was incredibly useful.
Yeah, thank you.
Yep. Any other comments? Any other questions?
Diwakar, we have also used the system of supervision from the Ministry of Health in Mali in our ICCM that assesses actually the quality of care and implementation strength of the project. That's the local system. We've been using it to supervise the CHWs every few months. I think every CHW has been supervised at least 6 times now. And it is less rigor than obviously than the one that Radar has, but it is still a useful system.
Thank you, Louis. I think that was very useful as well. So On the question of rigor, I would want to say that your tool is more to kind of facilitate the supportive supervision part rather than as an evaluative assessment, right? So I guess that's the reason why it's slightly structured different. So thank you. I assume you've been using that as a quality improvement tool, right? Kind of provide supportive supervision and improve the capacity of the CSW.
Correct. I mean, after 3 supervisions, you could see who is doing well and not, because the system has a rating way. So through points and further supervisions, we're focusing on certain CHWs that needed more coaching, because the system is supportive supervision. So it's not only collecting data and monitoring, but also providing coaching when they see a need for that. And that has enabled us to improve the quality of the services among all CHWs.
Thank you. Okay. So just to check with others, are we right on time? We are 11:52.
Yeah, we have 3 more minutes to do this, or we could move if there aren't any other comments or questions.
Yeah, just in case if there are folks who haven't listed a preference for the breakout rooms, feel free to type it into the chat box so that
people were very good. Thank you all for your quick responses. So I think I have a response from almost everybody for a breakout room, which is great. So just to confirm with our radar colleagues, we had originally planned for about 30 minutes. Does that still work for you and for the breakout rooms? Wonderful. All right, everybody. So momentarily, I'll be moving you into the room that you requested or were interested in, and I have just resent up at the top. If you didn't get it before, the link to the website and the password if you want to log into that. So just hang tight. If you haven't been in a breakout room before, it might look like your screen is closing down. It's not. It will take you to the breakout room, and all you've got to do is join in that discussion, and we'll bring you back in 30 minutes or so for the next step. So thanks a lot, and just hang tight while I open these rooms. And oh, you're all quick. I believe everybody is back. Melissa, so over to you.
Okay, great. Sadly, my group didn't have a ton of time to discuss. I don't know if other folks did. Tanya, are you saying no? Is that your no? You moved back and forth in a what I thought was a no. Did folks in other group have enough time to discuss?
Not enough. Tanya actually was cut in the middle of a question, so which is why I'm writing Tanya to ask her to type it into the chat box as well, so that we can address each of these questions.
Yeah, let's go ahead and take a good 15 minutes. And I'm sorry too that our group was just starting, and there was a really nice question being queued up. So let's bring some of those questions to this main group, and whether you put it in the chat box or you just ask it aloud. What questions did you have? What feedback did you have? What thoughts did you have from those presentations?
Tanya, would you like to go ahead with your question? I assume your question probably holds true for all the programs, right?
Yeah, I hope so. I guess my question was just in terms of alignment and timing. With Global Affairs Canada, we're about to be standing up a new round of proposals and new projects. And I was hearing from some of the others in our group that, the timing of the uptake of the tools and also the sharing of the findings of the results of the surveys undertaken don't always line up with the planned M&E that's already been developed in the project. So I was just wondering about how realistic it is for new projects to really embrace these tools and bring them on board. I know Oxfam mentioned that they're looking at some of the tools right now, but it just seems like sometimes the timing is one of the big challenges to be addressed, and the readiness of some of the partners to bring it in. I don't know if some of the partners want to speak to it as well, or JHU.
maybe I'll start and then open it up. These tools aren't perfect, they have benefited from input from the folks who use them, and were, the beneficiaries of their program benefited from the evaluation results, but they haven't benefited from this sort of thorough review of folks yet. But that said, it could be these tools are available to you to use, pick up now and use, and even the manuals are they're available now and they're being finalized. So these could be used and adapted now, and in the next month we'll be revising them according to feedback. So if programs have not already developed their M&E plan, or they're willing to review these tools and consider them, then I don't think it's too late. But if they need to be in the field now, it's too late. But let me just stop there and hear from the programs.
Yeah, if I can add to this, I do see that the quality of care and the strength of implementation are great tools for a midterm evaluation, thinking that sometimes during the lifetime of the project, an outcome-focused midterm does not make that much sense. But then a midterm that actually is helpful for us to feed to our how we can do better throughout the remaining of the project. It is very valuable. So maybe we don't need to have it 100% fleshed out at the baseline, but definitely within a year of implementation, that makes much more sense.
Thanks, Clarissa. That makes a lot of sense. So to reiterate what Clarissa has said, we usually do think of these tools as being used after the program is up and running. I mean, the one thing to consider, though, is you do want to think about funding them and putting enough time into your program plan and your evaluation plan from the beginning. So it is something to consider at the beginning, but the tools can still be adapted in the first year of the program without any problem. Other thoughts?
So one of the tools that might be of valuable use in planning are these sample size calculation tools. You could use them, use them to plan out your resources and plan out what kind of samples you'd be looking at and how much you probably might want to devote in terms of resources as well. Those supporting documents would be very useful at this point.
So Jasmine, who is in my session, is saying that it would have been useful to look at relationships between community health volunteers who are conducting nutrition referrals and cases treated for malnutrition, and looking to see whether building capacity and referrals could improve things. I think you're right. I mean, we can. I think we have posted the report, maybe not the Mozambique report yet, but we've posted the reports in case you want to look at findings more granularly to see if we've done more analysis than we were able to show today. Emily, can you remind me, did we post we didn't post the Mozambique report yet, right?
No, we're still finalizing the Mozambique report with INS. So nothing's officially completed yet, but I'm happy to talk offline. Jasmine, if you're interested in hearing more about what our findings were, I'm sure Melissa also presented some of that in the breakout room.
Yeah, that would be great. I just thought it was interesting based on looking at the initial results that there were some really good findings on knowledge, but then we saw that referrals were quite low, if I remember what I saw on the slide. And then I know just from an operational perspective, linkages between community health workers and facilities can be a challenge. So that might be something interesting to observe if there's any relationship between the two.
I quickly wanted to respond to Denise. Denise has this question about measuring sustainability regarding ICCM. So Denise, the overall objective of the radar suite of tools were more about attributing program to impact. And we were not exactly looking to look at and measure indicators of sustainability. So unfortunately, our tools haven't focused on that aspect of public health space. But there are so many other tools and evaluations that will probably kind of help you look at the sustainability aspect of many of these programs.
Yeah. Also, I just wanted to say for the family planning session, we were really just getting started on the discussion as well. It was really interesting to hear what all the other folks were planning and some of the things they were thinking about it. So I invite any of the participants to, unmute and, restate some of their questions if they didn't get a chance to ask. But also, I hope to see you all in the family planning specific feedback session, which I think we're going to learn more about in this session, but later in August. So thank you.
Thanks, Elizabeth. There were other questions. So in the intrapartum care group, we also had other questions about when would direct observations be kind of a suitable tool to measure quality of care, and is it always, do they always serve the purpose, and especially considering the amount of resources that we need to put into them. And we were kind of in the middle of a nice, good discussion about it. And one of the key things is it's all about what do we want to achieve with some of these assessments. So in some instances, we may never be able to get the right answer. So should we even be putting money into some of these assessments is a key question that we need to answer.
Does anyone who is participating in that discussion want to bring up any points?
I'm sorry, Barbara, but you're kind of my favorite person to pick on.
Well, I think one thing we started to get into that we didn't really have time to discuss is also beyond measuring quality of routine intrapartum care is management of obstetric and newborn complications and how to do that given their rare events. And under a previous project I worked on, we did try to do that, and we did use some observational assessment, but we only ended up with like 5 to 10 cases per country, even though we were trying to do national level assessments, but we just didn't have the caseloads at the facilities to get very many cases. But I'm really interested in hearing more about how vignettes and other approaches may be able to help us with looking at quality of care for those things.
If I could jump in on that point very quickly, I remember, Diwakar, when we were planning out the assessment for Tanzania, that was something that we spent quite a bit of time sort of figuring out. And I remember that kind of what we came away with was looking at volume for direct observation versus other things. And so in the case for Simiyu, obviously due to volume, we ended up using the vignettes quite a bit because there was just such a low volume of births happening. But I think what was interesting about using those dolls is that it allowed for a bit of time for capacity building as the assessment was happening. So I think that could be seen as a benefit for using these types of tools, because it's seen as a, in quotes, like a less urgent thing to coach a health provider through. So that was also some feedback that we got from regional officials, is that was an opportunity to do some capacity building at the same time. So that could be seen as a benefit.
Thanks, Jasmine. You touch upon a nice concept of using assessments as kind of capacity building exercises in themselves. Thank you. And this was another topic that we discussed in our small breakout rooms as to the availability of a certain volume of deliveries at a facility so that they could be eligible for direct observations. And as more and more programs concentrate on lower facilities and PMONC is kind of spread out into more and smaller facilities, we will probably come up with a situation where many facilities are too small to be evaluated using direct observations, or at least within the resources available, unless you want to expect a health work research collector to sit there for a month or so at a time, which is not reasonably possible. So that's where the concept of CVs and OSCEs as an alternative mode of assessment, even if it is the best possible scenario, as in it is the ceiling, right? We don't expect people to perform beyond what they perform in the CV or the OSCE, because we think that's probably their best possible performance. And
Diwakar,
anything, yeah.
Can you talk about how they related to each other, the findings of the validity study?
Oh, okay. Maybe quickly, briefly, is that we tried comparing some of these. So people who are not in the intrapartum group, I do need to go back and let you know that we developed case scenarios that worked with these Mama Natalie simulation dolls, which are to people who are not familiar with them, these are lifelike dolls that look like women and children and kind of can be used for practice and training. And we also tried without these dolls using case scenarios, like, for example, for people who have faced Viva OC examinations, you might have ended up being given scenarios that you were asked to respond to and provide a sequence of steps that you would take up in that situation. So we compared both these kind of assessments, and we found that many of them scored really high on reliability, as in they performed really well for both the OSCEs and the CVs. Like saying that, okay, these are some items that could be done without the OSCE dolls and just with clinical scenario in a Viva OC-like situation. And there were many that did not perform well in any of these situations. So there are so many indicators that do not perform well, no matter what you seem to want to assess in this scenarios. I think during our August 10th session, we'll probably go in greater detail into some of these individual indicators and kind of go in depth into how to think about some of these things. And this is kind of a teaser for those folks who want to come to that session. Yes, Melissa, I know we are approaching, we still have 20 minutes to go, and we want to use about 10 minutes to walk people through some of the website. So
I have a question.
Yeah.
Sorry, I have a question about I was part of the family planning group. So I have a question about the healthcare provider knowledge assessment. So it was quite detailed. I took a brief look at the tool, but does the guideline or the instructions manual, will it also provide us per question the right answers? Because, for example, there's a question on women who should not be prescribed injectables. I'm sure I can look it up on reliable information, but I don't want to misinterpret data, obviously. So would that be available? Because I just downloaded the zip file from the website and I don't think it had any instructions.
Yeah, no, thanks. That's a great question. That would definitely be part of the tool that would be customizable to each of the programs and each of the country context. But I think for Malawi, we did pull it from WHO, but we also tweaked it based on conversations with the Ministry of Health and review of their program documents as well. So in terms of, I'll have to go back and see in terms of do files and indicators and the guidelines itself, and we can go through this more in depth. There is sort of like a mapping document that shows how each of the indicators is formulated, but it's only the priority indicators. So it may not have included all of them that we assessed in Malawi, but that is something that, so to answer, that would be a customizable portion. So that could be something that could be changed. And we do have some feedback on that as well, or some information on that.
Actually, also that's a good point, considering I'm guessing each country, there might be slight variance in terms of guidelines.
Exactly.
So it would have to be tailored to each country.
Exactly. Yeah. And we tried to, in the guidelines, highlight which sections and which questions would need customization, but it would definitely be great to get your feedback on if more detail is needed in various places, for sure.
Okay.
Thank you.
And some of these details could be obtained through the do files in the statistical part of it. Like we have created some of these do files to create some of these indicators, and when you look through these do files, it will be kind of obvious as to what are the right answers and what needs to be, what would be an appropriate response in some instances.
Yeah, for Malawi.
Yeah.
In that case. But we did experience, and those of you who watched this journey with us for the specific question for the specific countries and the specific evaluation implementations will remember how much time we took to really understand both your program documents and the government's guidelines for treatment or addressing whatever health issue that we were trying to evaluate a program on. So it does take some time to make sure that this is customized, all customized to the local environment. And these tools can guide you, as Elizabeth said, on which aspects very much require that and which aspects might be standard. But for each implementation, that does take time, and it will be required at least for some indicators.
I do want to bring up something that came out in our group, which was ICCM. Lue had made the observation, which is very true, that our implementation in Mali with all of these tools took a lot of time, a lot of logistics, a lot of money, a lot of planning, and it may not be feasible for a program to do all of this as part of a monitoring and evaluation. I do want to say that hopefully with the guidelines that we will put out that accompany the tools, it will make it easier for program designers to kind of pick and choose which aspects of the tools and which methods you want to include in your evaluation plan. So it shouldn't be either you do all of this or you do none of this. We're hoping to create kind of a more interactive way for program designers to pick and choose which indicators, which variables, which domains they were interested. I don't think that will come to fruition, but I think that through looking at the guidance about the planning that needs to go into each of the methods and steps, I hope that it will be clear how to integrate these tools into your evaluation plan based on the resources available.
And a quick note, just as part of the supporting documents, we also have all these protocols that are used for these studies that are available on the website. So these are the IRB protocols that were submitted to describe the studies. So these can be used too as a kind of a template to describe some of your studies for your respective, say, IRB boards or other organizations where you need to kind of describe the study as well in a study protocol.
Just to add to what Diwakar and Emily just mentioned, I just wanted to share with the wider group some discussions we have throughout the process in terms of whether these evaluations must be led by external evaluator or if the project teams can lead the evaluations themselves, and what implications does it have in terms not only bias of the response, but also retaliation in terms of the community volunteers that are leading the process and how comfortable they are in terms of being evaluated by the project teams. And another discussion that I think was interesting was trying to gather across projects a diagnosis around, for example, the supply of nutrition supplements, and us as a collective being able to spot and report better on the gaps of the service and how we can best address that as programs. So those are two another finding that I thought it was interesting and good for us to tackle as a group.
Yeah, I think those are all really great points. Thanks, Clarissa. I do want to be mindful of the time and talk through our next section, which is about how we will go through the next steps in this process and how you can give feedback and we can continue these discussions. So let me share my screen. Can you all see the website I've pulled up?
Yes, we can.
Great, thank you. So this is hopefully the website. I don't know if any of you have accessed it before or not, but this is where everything will sort of live that you need in order to participate in all of these sessions and read the tools and give your feedback. So this is the homepage when you first come on the website, and you'll see up at the top here, each tool topic area has its own page. So we'll go to interpartum care, for example, and this is an example. This is one of the dolls Diwakar is talking about. This is a placenta from one of them that's used in the training materials. So you'll see that we, on each page, kind of describe a little bit about the tool, how they were developed, what it includes. And then we have the steps that we are going to go through for the next month. So right now we're in part 1, the introduction webinar. The next step will be the tool review. So we have links to all of the tools. They are on Google Docs, and I believe you will be able to put comments on the tools if you wish to do so. So we have a little description about each one of the forms, about what it includes. And then we have some additional resources. And my apologies is that they're not all available. Some of them are still being developed. But this is in the final package of the tools, kind of what will be included. And except for Mozambique, again, my apologies, they all also have the final report that we submitted for each program. Our Mali report is in French, but it should be coming in English very shortly. And then, as we mentioned before, every topic will have a follow-up webinar. So the interpartum specific webinar is on August 10th. We will hopefully soon have an RSVP link where you can register for this webinar. And we'll talk about the tools. We hope to really get a lot of your thoughts and feedback on using them and talk through how to make them more user-friendly. And then we will have, again, we haven't finished this section yet, but we will have a feedback survey. I know Jessica will also talk in a little bit about the feedback survey after this webinar. But just to show you this is interpartum care. We also have our family planning section, which has, again, more details about the evaluation and the tools, and every page looks like this. So I think she sent out the link and the password to access this. I see Jessica nodding. So this is kind of where anytime you need to access a resource, this is where you can find it.
Please feel free to email us anytime if you need any queries answered. And if you want to use any of these tools in the meanwhile for upcoming projects that you think probably you'll not be able to wait until that session, do not hesitate to ask us. We'll be always available to answer your queries and guide you in any way we can.
To give you just an example of one of the tools, so this is our family planning tool. You can click on it and it'll take you directly to a Google Docs link where you can open it with Google Docs and add comments that way. So these are how the tools will hopefully show up for you, should show up for you. I also just want to mention too, if you are interested in the other radar tools that are not the ISA or QOC, there's a link here to the radar website, which has information about all of the tools, the entire suite, including the ISA and QOC as well.
I just have a question for the family planning specific one. So again, like I said, my project is very SRHR, and I do want to not just focus on the family planning and contraceptive piece of our work. Is there like one person in the team who's more of a contact person for a specific theme of the tools, or is it like, how does this work? If your team is interested, if not, that also was fine.
I think you can, we all know most of the tools, but for family planning, your first stop could be to contact the person who ran the breakout room, and in that case, Elizabeth. Hazel would be that person, but Diwakar and I were also involved in that assessment. And then I guess for the other ICCM, Emily is the point person, but again, Diwakar and I were involved in that. And then Mozambique, we were, everyone but Elizabeth was involved in that. But yeah. Elizabeth is the, probably a good go-to person for the family planning tools.
Yeah, I hope our emails will be distributed to the participants, but feel free to reach out to me one-on-one, and we can have a call and talk to things further. And of course, we'll have an opportunity in the August sessions as well.
Yeah, they will be. I'll make a quick statement at the end, but emails will all be in a follow-up message.
So let me just ask, are people going to be able to look at these tools and give feedback? I mean, realistically, we would love it if each person on this call went through each set of tools and made comments on each indicator. But we know that your time is precious. The reason to prioritize it, as Marnie said, is that if these tools get your feedback and we can change them and improve them to make them more usable for you and more relevant and more specific for you, then they'll be easier for you to use. Let me just get a sense for whether people think they might have time to provide written feedback to the tools. Anybody feel like they could do that? I mean, not for all the tools necessarily, but for one set of tools.
Maybe you can give a thumbs up or a thumbs down if you don't want to say it out loud.
I know, like I said, like family planning one for sure. I guess I could take it one at a time. Yeah. In terms of thematic area.
I will provide comment on.
It doesn't have to be this week, Denise. Sorry, I interrupted someone.
I have a couple of comments on the ICCM tool. I will post it.
Terrific.
And as far as timeline goes, for each webinar is a different week. And so we're hoping that, feel free to participate in one of the webinars or all of the webinars, depending on your interest in the topic areas you're interested in. And then we are hoping that you will have time to review the tools before that webinar. And the dates of all of those are on the website. They're all in August.
There's a lot of interest in the interpartum and some interest in the family planning. That's so great. Please tell your colleagues who weren't able to participate that we would love their feedback as well. And even if it's just, one small comment in the margins, I think it can really help us. Thanks so much to everybody who replied. So I think, is there anything else, Emily, on your side? Great. So I think that I'll let Jessica have the last word, but let me just say from the radar team, it's been too short today. 2 hours seemed like a long time, but it's been too short today, and I wish I had more time with you guys. And I do hope that you're able to join and suggest to your colleagues that you join in August so that we can really dive deeper. We won't do this sort of intro kind of stuff then. We're going to dive into comments that have been made, concerns we have about the tools already, and we're going to really go in depth on discussing the tools then. So thanks for your participation today, and over to Jessica.
Was so good. I had everything ready, but I didn't unmute. I think we've said all the key points, but just again, on behalf of us at CanWaCH, huge thank you to, of course, the JHU team and our colleagues at Radar, as well to all of you for being here today and sharing your thoughts. There was a lot of discussion in this session, and lots of chatting. I was in and out of different groups, and it was great to see how much enthusiasm and thoughtful participation there was, so thank you. A couple of quick points. So to the point on emails, they're up here for you to jot down. But as mentioned, an email is going to be going out to everybody who participated in this session, even those who had to drop off. Just a few seconds ago, I also shared in the chat a link to a Google Doc form that will also go out in the email. It would be great if you could take a second and jot down if you're interested in participating in one of those follow-up discussions or multiple ones, it's up to you, to quickly just give us your name, your email, and which one you want to attend. Then in page 2 of that is a quick feedback evaluation survey, just to share some of your thoughts. And then as was mentioned, there's some opportunity to do some deep dive discussion. So feel free to note if that is something that is of interest to you. And anything else that you want to talk about, or any other follow-up points of conversation that you have for the JHU team, and we'll be sure to share that with them so that they can connect with you on that. And then finally, just to reiterate, as was mentioned, we will be recording these sessions. We'll be posting them online for you to be able to refer back to, and we will do our best to have this session up and available before the deep dive sessions start on August 10th. The sessions are August 10th, 17th, 24th, and 25th, so 3 Mondays and a Tuesday. And we'll try to have those up for you to be able to reference beforehand if possible. But we will let you know once that is available. So with that, again, my thanks, my gratitude to everybody for taking time today on their, hopefully sunny where you are Monday morning. And we look forward to seeing you all again in about a month or so. Take very good care. Bye for now.